Today we'll be discussing about epistaxis. Epistaxis means bleeding from the nose. See my previous video about blood supply of the nose before you read about epistaxis, because knowing the blood supply of the nose will help you identify where the blood is coming from the nose. According to Scott Brown, epistaxis can be classified in many ways. First classification is adult or pediatric or child, that is less than 16 years child. More than 16 years is considered as adult in case of epistaxis. Then whether it is primary or secondary. Primary means there is no identifiable cause. There is no proven cause, idiopathic. Secondary means there are causes that we can identify that has caused the nasal bleeding, like any trauma, any surgery, post-surgical, or any anticoagulant use, etc. Another type is whether it is anterior or whether it is posterior. That is from where the bleeding is coming, whether bleeding is coming from anterior or from posterior. Usually posterior bleeds are seen in adult, and patient will have bleeding from the nose and also from the mouth. Patient will be spitting out blood also. The fourth classification is whether it is very severe or it is less severe. Very severe requires hospitalization. Less severe recurrent is not so much life-threatening. Coming to causes, what are the causes of epistaxis? The causes can be one, that is local causes, that is due to problems in the nose. So problems in the nose causing bleeding from the nose. And also another one is systemic causes, that is the general problem with the body that causes bleeding from the nose. Local causes, what are the local causes? The local causes include any trauma to the nose. It can be any digital trauma like nose picking, especially in children, they will be doing this nose picking, or due to any accident or injury to the nose causing nasal bone fracture, laceration of the nasal mucosa, any foreign bodies that are lodged inside the nose, or any insertion of foreign bodies into the nose. Especially seen in children. If children are presenting with unilateral bloodstained nasal discharge or unilateral epistaxis recurrent, you have to think about a lodged foreign body inside the nose. Post-surgical, that is post any procedure on the nose causing bleeding from the nose. Another thing is any infection or inflammation of the nose. Inflammation of the nose is any allergic rhinitis, any other causes of rhinitis like autoimmune rhinitis, vaginous granulomatosis, all this causing inflammation of the nose. Any infections of the nose, the upper respiratory infection, sinusitis, nasal polyposis, other nasal infections, syphilis, all this can cause nasal bleeding. Vestibulitis, that is inflammation of this upper part of the nose, and the patient is nose picking and the crust will be formed, so they will remove the crust and it can cause nasal bleeding. Then any nasal masses. Nasal masses can be benign or malignant. Any carcinoma of the maxilla, carcinoma of the nasopharynx, inverted papilloma, nasal masses like juvenile nasopharyngeal angiofibroma, hemangiopericytoma, all this can present with profuse, painless, recurrent epistaxis. Especially if a young adult or an adolescent boy is presenting with profuse recurrent epistaxis, painless epistaxis with nasal block, think about JNA. Usually this nasal masses will have other contributing symptoms also, like nasal block, nasal discharge, and all that will be associated symptoms will be present. Coming to systemic causes. What are the systemic causes? Any clotting abnormalities in the body. That is primary clotting abnormalities like your von Willebrand's disease, hemophilia, leukemia, myelosuppression, ITP, idiopathic thrombocytopenic purpura. All this can present with nasal bleed. Also any secondary coagulopathy. That is coagulopathy due to a systemic disease like chronic liver failure, chronic renal failure, chronic alcohol use causing chronic liver failure. All this can present with epistaxis. Another systemic cause is hypertension. So elevated DP causing rupture of the minor blood vessels of the nose causing epistaxis. Most of these patients may not be aware that they have a high BP, or patients who are chronic hypertensive patients who have discontinued treatment or missed medications, all that they can have a raise in BP and present with epistaxis. Different studies have been done, and studies does not show a direct association between hypertension and epistaxis, but clinical practice show that many of the patients have hypertension either undetected or any uncontrolled hypertension can present with epistaxis. Another cause is medication. Medications like NSAIDs, self-medication with pain medications like NSAIDs, aspirin. Then patients on anticoagulants like warfarin therapy, platelet aggregation inhibitors like clopidogrel, topical medications like patients using nasal sprays causing irritation of the nasal mucosa, and also illicit drugs like cocaine use, and also exposure to chemical agents like chemical fumes in patients who work in chemical factory and all, chemical fumes, acid, chlorides, etc. If they're exposed to, the mucosa can be affected and there can be bleeding from the nose. Also, environmental factors like the air quality, the pollution in the atmosphere, and can also affect the status of the nasal mucosa, causing epistaxis. For any disease, I have explained this in my previous video also. There is a technique where you can bring out the causes. That is whether it is due to trauma, is it due to infection, is it due to inflammation, is it due to any tumors, is it nutritional, is it due to environment. If you think about all these factors, you will get multiple causes which causes a disease. Before coming to treatment of epistaxis, let us revise some key clinical areas from where the epistaxis happened. Please go through my previous video on blood supply of nose for identifying the key clinical areas. First one is the Little's area or the Kesselbach's plexus, where the anterior epistaxis happens. Then you have another plexus known as Woodruff's plexus. The Kesselbach's plexus is present in the antero-inferior part of the septum. The Woodruff's plexus is present in the lateral nasal wall. At the posterior end of the inferior turbinate, that is posterior end of the lateral nasal wall, recent studies show that it is a venous plexus and posterior epistaxis can happen from this venous plexus. Another plexus seen in the nose is Brown's plexus, and also in children there is a retrocolumnar. This is columnar, so there is a retrocolumnar vein from which venous bleeding can occur due to recurrent nose picking. So these are the major sites from which the bleed occurs. Which is the artery of epistaxis? Artery of epistaxis is sphenopalatine artery, the posterior septal branch of the sphenopalatine artery. Coming to management of epistaxis. Epistaxis is an emergency. The patient must be resuscitated. That is, if the patient is coming to the OPD or the emergency room with active nasal bleeding, patient has to be resuscitated immediately. Our ABC of resuscitation is ABC, that is airway, breathing, circulation. We should see whether the patient's airway is patent, whether the patient is breathing properly, whether SpO2 is normal, and what about check the blood pressure, vitals, everything, whether the patient is stable. The patient should be examined in a semi-recumbent position. That is, the patient should not be made to lie down flat. Patient should not be made to sit up fully. Patient can slightly sit in a semi-recumbent position. We can use the help of a nursing assistant to help us. It is better to have two people around for help, and also better to use up all the protective equipments and all that, because any aerosol infection from the blood should not happen to you. So universal precautions you can follow while examining the patient when the patient is actively bleeding. The history and examination should go side by side with the resuscitation. So the patient is bleeding anteriorly. You can ask the patient to slightly lean forward and pinch the ala nasal. So this is known as Hippocratic technique. Pinch the LNSA and ask them to keep the mouth open so that they can breathe through the mouth and the nose is pinched. So the pressure will reduce the bleeding from the anterior part of the nose. So simultaneously, you take a history, whether the patient has been traveling, whether the patient is on any medication, any history of trauma, any history of infection, any history of previous bleeding. All this history taking has to go simultaneously and examine the patient. When your staff or the nurse is examining for the BP, pulse, everything. If the patient is actively bleeding, you have to secure an IV line, and simultaneously blood can be drawn to check for basic investigations like hemoglobin, platelet levels, and if the patient is on any anticoagulant therapy, you can see the PT, INR, BTCT, everything can be done. The main management can be divided into two types of therapy. First one is direct therapy. Second one is indirect therapy. Direct therapy, you think direct. That means directly identify from where the blood is coming, directly identify the bleeding point and cauterize it. Indirect therapies, we are not able to identify the bleeding point, so we treat the patient generally. That is indirect therapy. So when we examine the patient, put the headlight and see if you are able to assess the bleeding point. If the bleeding point is seen in the headlights, that is, it is an anterior epistaxis. So anterior epistaxis is from the anterior part of the nose, that is bleeding from a source anterior to the plane of the pyriform aperture. That includes anterior septum, mucocutaneous junction, and the vestibule. So this is anterior epistaxis. Posterior epistaxis is bleeding from the nose posterior to the plane of the pyriform aperture. That includes the septum floor and the lateral nasal wall. If you are able to see the bleeding point or vessel with headlight itself, it is mainly from the anterior part of the nose, and it can be treated by direct therapy with giving pressure to that area, or you can use chemical cauterize like silver nitrate and stop the bleeding. But if you are not able to see the bleeding, you can go for a diagnostic nasal endoscopy and see if you can identify the bleeding point, and then you can cauterize the bleeding point using a bipolar cautery. That is direct therapy. But if you are not able to see the bleeding point and the patient is profusely bleeding, you have to go for indirect therapy only. What are the indirect therapies that we know of? What we use commonly is nasal packing. There is anterior nasal packing and posterior nasal packing. Initially, we do the anteronasal packing and see if the bleeding can be controlled. And if it is not controlled, even with the anteronasal packing, you have to go for a postnasal packing. Anteronasal packing, we use the ribbon gauze filled with the liquid paraffin, or you can use petroleum jelly, and it is inserted on top of one another, layer by layer. From the floor, you have to keep it one above the other till you pack the nose completely. That is how the anterior packing is done. And once you keep a nasal pack inside, you have to start the patient on antibiotic, and the nasal packing can be removed after 24 to 48 hours if the bleeding is arrested. We also have special ready-made tampons for anteronasal packing like Mirosil, Caltostat, and also you can use balloon catheters. If the bleeding is not getting arrested with anteronasal packing, you have to go for a posterior nasal packing. Posterior nasal packing means posterior part of the septum, that the posterior end of the infraturbinate or posterior end of the septum, we need to give a tamponade. What the nasal packing is doing is giving a tamponade. The pressure is given so that the blood vessel is blocked and the bleeding is stopping. That is what the nasal packing does. What we do usually is use a Foley catheter for posterior nasal packing. There are traditional gauze methods and posterior nasal packing, Miro seals are also available. Foley catheter, how you do it? So you can use a size 12 or 14. Insert it along the floor of the nose till the nasopharynx is reached. Then the Foley catheter will have a bulb. That bulb is inflated with 15 ml of water, and then it is pulled forward so that the bulb will come and press on the posterior choana, and the posterior tamponade is given. And then after doing a posterior nasal packing, you keep an anterior nasal packing also for extra support. And this Foley catheter has to be fixed anteriorly. Make sure that you spare the columella. Here, if you get injured or give too much pressure, this area will get necrosed. That is a complication. That is, there can be pressure necrosis of the columella, ala, septum, etc. Because of the too much pressure, the blood supply will be totally cut off and there can be pressure necrosis. You have to keep that in mind. What are the other complications? Because of the anterior nasal packing, the patient can get hypoxia. The posterior nasal packing also can cause hypoxia. Posterior nasal packing extra can cause there is edema of the soft palate and again hypoxia. Posterior nasal packing, the patient will have some considerable pain. Both anterior and posterior nasal packing can cause sinusitis because secretions can collect inside sinus, sinusitis, middle ear effusion. Some studies say that the patient can develop an MI also because of the pressure produced by the nasal packing. Even after the packing, there is bleeding is there, means you have to take the patient to OT. Once the patient is coming with an active nasal bleed, the bleeding has to be arrested within 24 hours in the hospital. The patient should not be walking around in the ward with a nasal pack in situ, but with the bleeding. That should not happen. If that happens, the patient has to be taken to the OT and exploration has to be done. Simultaneously, you can start a systemic medical therapy. That is your tranexamic acid and also epsilon aminocaproic acid. Tranexamic acid, you can give as injection or tablet tranexamic acid can be given. These are systemic inhibitors of fibrinolysis. They have shown to reduce the severity and also reduce the recurrence of epistaxis. So tranexamic acid is a very good drug. The tranexamic acid does not increase the fibrin deposition. It actually reduces the fibrinolysis. So it does not cause increase in thrombosis usually. And you can give to a dose of 1.5 gram 3 times a day. These are all adjuvant therapies. Also, topical hemostatic agents are available like Flosil. These are adjuvant therapies that you can use simultaneously with your nasal packing. If it is a systemic cause, simultaneously you have to correct the systemic problem. Like if the patient is having platelet deficiency, patient is having raised bleeding time, clotting time, you have to correct that, correct the platelet levels, correct the bleeding time, clotting time. The patient is having liver failure. Systemic issue has to be corrected simultaneously while you manage the local treatment. If all these methods are failing, what are the surgical methods? Surgical methods are ligation techniques. So revise the blood supply of the nose. Branches of the external and internal carotid arteries are coming. External carotid artery is the main supply. The sphenopalatine artery is the artery of epistaxis. So what we do is we ligate the supply. We ligate the sphenopalatine artery, that is known as endoscopic endonasal sphenopalatine artery ligation, ESPAL. So the sphenopalatine artery can be identified in the sphenopalatine foramen. If it is endoscopic endonasal under GA, usually we do under GA. Some people do under LA also. Under GA, under endoscopic guidance, an incision approximately 8 mm is made anterior to and under the cover of the posterior end of the middle turbinate. The incision is carried down to the base and the mucosal flap is elevated posteriorly until the fibroneurovascular sleeve arising from the sphenopalatine foramen is identified. You can use crista ethmoidalis as a landmark, and the sphenopalatine artery is identified, and you can ligate it. Usually we use ligatures for hemostatic clips, or you can also use a bipolar cautery. Monopolar cautery is usually not used. Complications are rebleeding, infections, any nasal adhesions or syncytial formations, etc. First, we try to ligate the sphenopalatine artery. Sphenopalatine artery is a terminal branch of the internal maxillary artery. This is not working. We have to go to the next. So this is like a pipeline. So one place it is not working, go to the next. So that is the direction in which we follow. So sphenopalatine first we tried, it failed, means you have to go for internal maxillary artery ligation in the pterygopalatine fossa. It can be approached transanterally via sublabial approach like this, that is anterior approach. Also combined approach like via sublabial approach and also through the nose, that is a medial approach. So medially and anteriorly, both together you can approach the internal maxillary artery. Sublabial approach, a sublabial androstomy is performed and the mucosa of the posterior wall of the maxillary sinus is elevated and the window is created into the pterygopalatine fossa. We should take care to not injure the infraorbital nerve. Combined approach means you use the sublabial approach to create a small canine fossa androstomy and insert the endoscope only through the sublabial approach. And instrumentation, you do a middle meatal androstomy and put your instruments through the nose. So instruments through the nose and endoscope through the canine fossa androstomy. Combined approach also you can do. End of the internal maxillary artery, so descending palatine artery and the sphenopalatine artery is clipped or ligated and cauterized. Complication of the internal maxillary artery ligation include injury to the infraorbital nerve, sinusitis, oroantral fistula, ophthalmoplegia, vision loss, etc. This is also not working. Means the next step is internal maxillary artery is a branch of external carotid artery. So if this is also not working, as an extreme step, you can go for ligation of the external carotid artery. So external carotid artery ligation is done via the neck. In the neck, you make a longitudinal crease incision parallel to the anterior border of the sternocleidomastoid, and then identify the carotid bifurcation, identify the external carotid artery, and you can go for external carotid artery ligation. This is an extreme step. There can be a lot of complications. Then the ligation of the anterior and posterior ethmoidal arteries. Although anterior and posterior ethmoidal artery bleed is very less because they contribute very less only to the septum. It is not so much attempted procedure to do an anterior or posterior ethmoidal artery ligation. Approach it via a medial candle incision and then extend it to the bone over the lacrimal crest and then approach the anterior ethmoidal artery. Also endoscopic endonasal anterior ethmoidal artery ligation via ethmoids are also described. So if you want to know more about that topic, I will be doing it in another video. If the bleeding is not getting control with all your ligation, you can go for another technique is embolization. Embolization under digital subtraction angiography. We usually use transfemoral Seldinger angiography and the blood supply of the nose is identified. And the bleeding point, the bleeding vessels are identified. We have to exclude any aneurysm, arteriovenous malformations and fistula before doing the embolization. Fine catheter is passed via the internal maxillary artery and we embolize. The materials used are polyvinyl alcohol, tungsten or steel microcoils. When you embolize the internal maxillary artery, simultaneously ipsilateral facial artery is also embolized to prevent any collateral circulation formation. Complications are skin necrosis, paresthesia, facial issues due to embolization of the facial artery, groin problems because we insert the catheter via femoral area, groin hematomas. Patient can also develop a cerebrovascular accident. What are the other surgical treatments that you can do? If the cause is due to a septal spur, you can do a septoplasty or a submucous resection of the septum, especially with prominent septal deviation, vomeronasal spur, etc. When we elevate the flap itself, the blood supply is cut off, so bleeding will get arrested in such cases. One more tip, patients on warfarin. In patients on warfarin, our direct therapies will not work because the bleeding can be from multiple points, and if you try to put instrument, we will injure the mucosa more and there will be more bleeding. So it is better to go for indirect therapy like nasal packing and also consult with the cardiologist and hematologist and for the reason why the patient is taking warfarin and discuss if we can reduce the dose. Latest anticoagulants like rivaroxaban, dabigatran acts by a different mechanism, not the usual mechanism of vitamin K inhibition. To reverse the effect of this will take more time than that with warfarin. We can consult with the hematologist and decide whether to discontinue the medication or not. Summarizing, actively bleeding patient, you have to resuscitate immediately. After resuscitation, see if you are able to identify the bleed. If you are able to identify the bleed, go for direct therapy, any chemical cautery or pressure application. And if it is postal bleed, do an endoscopy. And if you are identifying, you can cauterize the bleeding point. If you are not able to identify the bleeding vessel, go for indirect therapy like nasal packing. And if the patient is not responding to nasal packing and direct therapies, go for surgical management like ligation of the arteries. If the ligation of the arteries are not working, go for embolization. Also, if it is a systemic cause, simultaneously treat the systemic cause